Thank you so much for joining us this evening for the first session of our Northeast Region Wellness Symposium. I want to thank you for attending, and I would like to say a special thank you for this program is made possible by individuals and partners dedicated to providing learning opportunities and a platform for our teal community to be inspired. A special thank you to our presenting partner, Northwell Health, and our national partners that includes GSK, Merck, Eisai, and Novocure. And tonight's topic is going to be everything you needed to know but didn't have the guts to ask: ovarian cancer and gastrointestinal issues. So to begin, I am going to introduce the speakers this evening. So the first speaker that is going to be joining us is Dr. Elena Pereira, is a gynecological oncologist at Lenox Hill Hospital. She is double board certified in obstetrics and gynecology and gynecological oncology. So welcome, Dr. Elena Pereira. And thank you so much for joining us tonight and sharing your expertise. The next speaker that I would like to introduce everybody to is Dr. Cecilia Birisan. Dr. Birisan, do you want to say hi just so everybody could see you on the screen as I introduce you?
Sure. Hello, everyone.
Yeah, thank you. This is Dr. Cecilia Birisan, is a colorectal surgeon at Northwell Health. She treats a wide range of conditions of the small intestine, colon, rectum, including inflammatory bowel disease, rectal disorders, pelvic floor disorders, and colorectal cancer. And we thank her for being with us tonight and sharing her expertise. And also, I would like to introduce one other special guest that is joining us from the Northwell Health family. Many of you may know her. I would like to introduce Valerie Berger. Valerie,
Hi.
would you just like to say hi this evening? Thank you very much for joining us. Valerie is the Assistant VP of Cancer Services for the Eastern Region, and she has worked diligently with me to help us ensure that we have a wonderful program throughout this entire series to help you make informed decisions. So with that said, I would like to welcome everybody tonight, and I would like to begin with Dr. Pereira is going to begin our discussion tonight. So Dr. Pereira, we're going to turn it over to you now.
Great, thank you. And thank you for having me. I'm really excited to be here. And I think these talks are really, really important. So I'm going to share my screen and we will get started. How does that look?
I think it looks great.
Okay. So the topic tonight is bowel issues with ovarian cancer, but I kind of wanted to start a little bit with a background on ovarian cancer. A lot of this is things that many of you already know, but sort of at the root of it, ovarian and fallopian tube cancers are the second most common GYN cancers, with an incidence of about 26,000 patients annually, and that breaks down to 1 in 70 women. Epithelial ovarian cancers are the most common subtype, and these constitute about 90% of the malignant types of ovarian cancer. And it's these epithelial ovarian tumors that are most associated with GI and bowel issues. And so that will really be a big focus of our talk tonight. The reason for this is because ovarian and fallopian tube cancers spread along the surfaces of the abdominal cavity. And because they do this, they're able to implant on organs in the belly, and in cases like small and large intestines. And so the reason this happens is because the abdominal cavity is essentially washed with peritoneal fluid, and there's really a circulation that happens. And when these ovarian tumors have an opportunity to kind of chip off or release cells from the primary tumor, they're taken into the belly and they can sometimes just implant where they land. And so when we're managing primary ovarian cancer, patients with a new diagnosis will be assessed for whether or not they can have a primary surgery, or whether or not they're a better candidate for perhaps starting with chemotherapy with a plan to go and do surgery after. And the goal of these surgeries is to remove the uterus, the ovaries, the fallopian tubes, but also all of the tumor that is visible to the surgeon's eye. And in many cases, this results in resection of either the small bowel or the large intestine. Also because the tumors can implant in these places, a lot of patients, that's the first symptom that they'll feel. Often GI upset is what brings patients to the doctor and what allows us to find these tumors. And so the combination of carboplatin and paclitaxel really is the backbone of treatment. And the reason it's the backbone of treatment is because it's very effective and because it's fairly well tolerated. So about 70% of women with advanced ovarian cancer will achieve a complete clinical remission after their initial surgery with this platinum-based chemotherapy. When I say it's fairly well tolerated, what I really mean is that patients are able to tolerate the side effects, and we're able to manage the side effects in a way that allows sort of the best quality of life. It's still chemotherapy, and many of you have had this regimen. But one of the things that we found in particular is that carboplatin is slightly less associated with things like nausea and stomach upset than its cousin cisplatin, which is what we originally used. Cisplatin used to be the backbone of treatment, but carboplatin is better tolerated by patients, and a big part of that is the nausea element. For patients with certain inherited mutations, the BRCA mutation being quite well known at this point, medications, targeted therapies such as PARP inhibitors are also an option for upfront therapy. And so kind of bowel obstruction in ovarian cancer. So as I mentioned earlier, many patients, the first symptom that they present with when they are newly diagnosed is some stomach upset, either nausea or bloating or constipation, or just changes in their bowel habits, changes in their appetite. About 50% of patients with ovarian cancer will develop some type of bowel obstruction at some point over the natural course of their disease. And this is either complete or partial. And these symptoms can originate either in the small intestines, the large intestines, or in some cases, both. The management of bowel obstruction is complex, and for this reason, it will often involve a multidisciplinary team approach with surgeons, oncologists, palliative care, physicians, nurses, dietitians, really a whole team. And so the causes of these obstructions, it's not one size fits all. There are many different reasons, and there's partial obstructions, there's complete obstructions. It can either be a focal obstruction from a discrete tumor. Sometimes it's multiple implants along, for example, the small bowel, which will create some just functional obstruction. Really, the muscles of the bowel are having trouble moving the way they're supposed to because these implants kind of paralyze the muscle locally. Sometimes it's something as simple as a postoperative adhesion. And sometimes patients will be fairly functional with a partial bowel obstruction, and then they eat something that kind of causes a full bowel obstruction. And so what's the initial management? Say a patient is feeling nauseous or bloated, or they're vomiting, they're not passing gas, they haven't had a bowel movement in several days. I think it's first important to recognize what are the symptoms of an acute bowel obstruction. And really, the most obvious things are bloating, nausea, and vomiting. Typically, patients will be brought into the emergency room if there's a concern for an obstruction, and we will start with hydration and typically decompression of the stomach with the focus of decompressing the rest of the bowel. The reason this is important is because when there is a blockage, if things can't go down, they're going to start coming back up. And so while the nasogastric tube is uncomfortable in itself, many patients actually feel relief from it because it relieves that nausea, that nausea and that vomiting. And it essentially decompresses all the gases and all the fluids that your stomach and your intestines naturally make. And in some cases, just that decompression will allow the bowel to become functional again. And that's why that's the first step with the management of a bowel obstruction. Because what happens when the bowel is dilated is it gets swollen, it gets edematous, and the muscle doesn't work as well as it's supposed to. And by decompressing the bowel, you can really encourage it to start pushing the gases and the food down in the right direction. A CAT scan is typically done to really assess what's going on. I kind of glossed over it, but one of the things on my last slide was the word ileus. And I think it's helpful to understand the difference between an ileus and a bowel obstruction. An ileus and a bowel obstruction can actually present in very similar ways. But in a case of ileus, the bowel is kind of paralyzed. It's not moving the way it's supposed to. And of course, with an obstruction, the bowel is blocked in some way. And so a CAT scan can be really helpful in distinguishing between a true blockage and something that's more of an ileus picture. And then after these initial steps, patients are monitored for signs and symptoms of improvement, which will often look like decrease. They're not as distended. Less is coming out of the NG tube. The bowels will start to the sounds coming out of the bowels will start to normalize, and there will be return of bowel function. And so the conservative management of obstruction includes other things as well. And so pain is often managed with a combination of narcotics and non-steroidal like Motrins and Tylenols. And then the nausea is managed with nausea medication, of course. And the selection of the nausea medication in the setting of an actual obstruction is really important, because some of the nausea medication that we use for the management of nausea in like the setting of chemotherapy, while those are effective nausea medications, they might cause things like bowel stimulation, which would cause cramping and other uncomfortable symptoms that you wouldn't want to encourage in a patient who has either a partial or a complete obstruction. And so we'll often select antiemetics that don't cause that stimulation. Zofran is a common one. Compazine is a common one. Sometimes we'll use steroids. Dexamethasone is an excellent nausea medication. And in some cases, if there is still nausea, if that feeling of nausea is intractable, then we'll use other classes of medications. Some are in the antipsychotic category. And I think the most important takeaway point from this slide is that we have a lot of tools in our box. There are a lot of medications that are very effective for nausea. And this whole list can be used together. It's not like you have to pick one or the other. And so together with the palliative care team, I think we do a really effective job of managing nausea with these things. One thing that I wanted to highlight, and the reason I kind of put it in its own bubble, is I think it's important to keep in mind that when a patient has a bowel obstruction, they don't typically feel hungry. It's not an uncommon scenario where I'll have a patient admitted to the hospital and there's a lot of concern and a lot of anxiety around not feeding, not receiving adequate nutrition. And for these conservative managements, these like temporary managements of bowel obstruction, patients don't typically feel hungry. We usually will just use very simple fluid hydration rather than trying to give nutrition through the IV. I mentioned earlier, colics and spasms, sort of the intestines trying to work through the obstruction can sometimes be the most uncomfortable part of the bowel obstruction symptoms. And so we'll use medications that stop the secretion of the fluids that the gut naturally makes. And for women who do not improve with conservative management, that's when we start considering options for long-term decompression or surgery can be considered. And this is not the bulk of my talk. Dr. Birisan will be taking over for the surgical management, but I just wanted to briefly kind of touch on how we navigate who is an optimal candidate for surgery in the setting of a malignant bowel obstruction. It's a decision that has to be weighed very carefully. We always weigh surgical decisions carefully. We always want to make sure to first do good and not cause harm. And so when we are assessing whether or not a patient is an ideal candidate for surgery, we first ask ourselves, is the surgery going to help? But also we want to ask ourselves, is the surgery going to hurt? And studies have shown that surgery has higher risk of morbidity and mortality in older patients, patients with poor nutrition status, patients who have a chemotherapy-resistant tumor or received recent chemotherapy, patients with ascites, and patients with large tumor burden or multiple sites of tumor. And so that kind of a little bit of a segue. And so more on surgical management from Dr. Birisan. I'm going to stop sharing.
Dr. Pereira, and
Yeah.
now we are going to switch over to Dr. Birisan. Dr. Birisan.
All right, let me just take a moment to share my slides.
Okay, take your time.
And is everybody able to see my presentation?
Yes, we could see it. Oh,
Yep, it's perfect.
perfect.
All right.
There we go.
Great. All right. Well, thank you, Stephanie, for your introduction earlier. Once again, I'm Cecilia Birisan. I'm a colon and rectal surgeon with Northwell Health on Long Island, and I'm delighted to be here. I really feel that patient education is just such an important tool to help people take charge of their health and advocate for themselves. So I know that talking about the GI tract and how it's working can seem really awkward and really embarrassing. I very much get this. I'm a colorectal surgeon, and folks just don't really want to talk about that. It's not part of what we do normally in society. So here's what I tell my patients. I tell them that I talk about bowel movements and all of that the same way that a pulmonologist talks about breathing. So all of that said, my biggest goal today is to give you all an understanding, the tools, the language you need to discuss these issues with your physicians if they ever arise. So we'll go through a few different topics. Dr. Pereira did an excellent job with going over the management of bowel obstructions in general and how they relate to ovarian cancer. And so I'll explain further how we decide whether to operate and find that optimal candidate. I'll briefly review the types of surgeries that can be done to treat bowel obstruction. And this can include things like a colostomy and ileostomy, things that we commonly refer to as a bag. And I'll explain the differences between those two things. And then lastly, changing some gears slightly, we'll briefly review the other potential options to manage obstructive type symptoms as well as chronic diarrhea. So a lot of things in surgery are just like plumbing. The only thing is we're using some flexible piping instead of copper or PVC. And then obstruction refers to a blockage in the GI tract plumbing, whether it's from a scar from prior surgery, like an adhesion, causing some sort of kink, or in the case of certain cancers like ovarian cancer, compression from a mass outside of the intestine. Symptoms are generally related to a blockage in the plumbing. So as Dr. Pereira mentioned earlier, if the contents of the GI tract cannot move forward, it causes distension of the upstream structures until it eventually backs up into the stomach. And this causes nausea, vomiting, and abdominal pain. So these are the most common symptoms associated with bowel obstruction. Constipation and an inability to pass gas can also be seen. But if the bowel is only partially obstructed, those symptoms may or may not be present. So pretty much it's the nausea, vomiting, and abdominal pain that are the clinical clues. And so Dr. Pereira already reviewed this, so I'll move through this quickly. Obstruction is often diagnosed clinically just by talking to a patient, doing an exam, and it's confirmed on imaging, which is typically a CT scan. This offers some very good detail about the involved structures and can help guide some future treatments. Non-surgical management, which has already been discussed, involves holding off on any eating or drinking, oftentimes placement of a nasogastric tube through the nose in order to drain the stomach and relieve pain, nausea, and vomiting, and also giving some IV fluids. If this in and of itself is enough to resolve the bowel obstruction, then the diet is slowly advanced back to probably a low fiber diet. I'll get into that a little bit more later. Now, procedures to intervene on bowel obstruction and do surgery, those are done in very specific situations. Again, because we don't want to do any harm. We want to help. That's what we're here for. We're here to listen. We're here to help. And so we want to make sure that we are not going to make a situation worse. So as with any surgery, there are risks, and these are not insignificant. And so because of its very nature, because of the disease's very nature, complications such as reobstruction, readmission to the hospital, those can occur fairly frequently. And with any surgery, there comes a risk of mortality. But in terms of the benefits, if the disease is amenable to surgery, an operation can be associated with a prolonged survival. It can be associated with an ability to resume eating and drinking, and it can possibly allow the patient to get to chemotherapy for future treatments. Risks and benefits are always running through a surgeon's mind whenever we're considering whether to proceed with an operation. We really want to help, we don't want to harm. And so a realistic discussion about risks, benefits, and feasibility of the operation should be held between the patient and the providers. Oftentimes, this is in a multidisciplinary fashion, for instance, with the aid of the palliative care team to facilitate this kind of discussion, just so we can determine the best course of action. So these next several slides are going to kind of go over the things that are running through a surgeon's mind and the things that we discuss with the patients in order to decide whether surgery is a good and safe option. So the first question is the surgery technically feasible? We ask ourselves, all right, where is this obstruction located? Excuse me. So just as a quick overview, food goes from the esophagus into the stomach, then through the small intestine, and then through the large intestine, and then out. If the obstruction is on the large intestine, which happens about 31% of the time, this tends to be in a more focal area. Plus, the colon is thinner walled than the small intestine, so there's a higher chance of complications like perforation from the obstruction itself. And because of this, surgery is more likely to be recommended in the case of a large intestinal blockage. For the small intestine, these small bowel obstructions tend to be due to more diffusely spread, less focal involvement with the cancer, this carcinomatosis. And so the surgery tends to be much more difficult, and non-operative management is more likely to be recommended if that is possible. But if there is evidence that the disease is more limited, then surgery could be a possibility. We also ask ourselves if it's physically possible to adequately mobilize structures so we can know what's up, what's down, what's right, what's left, and then basically just get on with what we need to do in order to relieve the obstruction. Unfortunately, just because of the diffuse nature of some disease in certain cases, this just is not possible. The second consideration, is the patient fit both physically and emotionally for the surgery and recovery? I always tell my patients who are undergoing any kind of complex surgery that it's not just getting through the operation, it's the long-term recovery afterward that also needs to be overcome. There are some cases where it just isn't safe at all to proceed with surgery, which Dr. Pereira already touched on as well. In cases where there's very diffuse cancer spread, this diffuse carcinomatosis, if there's a large amount of ascites that builds up very quickly, this really rapid fluid buildup, if the very, very upstream portion of the stomach is involved, and if there was already a previous operation which showed that the disease was in such a state that it's just not physically possible to do anything that's corrective, These are things that would mean that our hands are a little tied, and unfortunately, we just cannot, in good conscience, recommend an operation. There are some other considerations that are relative contraindications, meaning that it's not an absolute no, but it definitely makes us hesitate. So if a patient has poor performance status, or is very frail, or has not the greatest nutrition, that's a reason to somewhat hesitate. Previous radiation to the abdomen or pelvis, this while it is used to sometimes treat certain diseases, it can impede healing because of the damaging nature of the radiation. Additionally, if there's extensive disease outside the abdomen, not just this carcinomatosis, but spread, for instance, to the lung, then we also need to ask ourselves, is surgery really the best option? Last, and then this is another part of this patient and physician conversation, is the patient likely to benefit from the operation? And here's what we need to consider here. What exactly are the goals of the surgery? Surgery to treat these obstructions caused by cancer is generally meant to be palliative, to relieve symptoms. It's not meant to cure the disease. And so we have to figure out what exactly is the goal here. Is the goal to be able to eat and drink again? Is it maybe to just do something more minimal, but at least relieve that nausea, vomiting, and pain in a way that does not need constant hospitalization? Frequently these operations require an ostomy, which could potentially be permanent. And if that's potentially needed, is that something that the patient is willing to deal with? And so with all of these considerations in mind, we ask ourselves, do the benefits outweigh the risks? And if they seem to, then we can say, all right, let's proceed with an operation. Just summing up the three considerations one last time. Number one, is it feasible? Number two, is the patient physically and emotionally fit to undergo the surgery and to the recovery? And three, will it be beneficial? So who does these operations? And as I understand it, we have folks kind of from all over who are tuning into this call. So who does these operations may depend a little bit on the resources at your particular hospital. But involved surgeons can include surgical and gynecologic oncologists, colorectal surgeons, general surgeons, and for certain procedures, a gastroenterologist may be involved. This is a list of potential procedures to treat obstruction, listed somewhat in order of least to most invasive, and I'll go all of them individually. So first is the PEG tube. This stands for percutaneous endoscopic gastrostomy tube, and it's placed either by a surgeon or a gastroenterologist using an upper GI scope. Involves no incisions other than the site where the tube is made to exit through the skin. And essentially the tube is placed in the stomach and then allowed to exit through the skin, and then can be used to either drain the contents of the stomach in the case of a chronic obstruction, and this will allow relief of the nausea, vomiting, and abdominal pain. Or let's say the obstruction resolves and it is safe to feed, it could potentially be used for feeding occasionally. A non-operative treatment that was mentioned earlier was the nasogastric tube, but the nasogastric tube, it's passing through the nose, it's going into the stomach, like past the throat, and then it's used to drain the stomach, and that's just not something that can stay in place long-term. So the PEG tube can remain in place long-term and is a way to basically allow drainage of the gastric contents without needing to constantly come into the hospital. The goal with this treatment, like I mentioned, it's to provide a way to relieve the nausea, vomiting, and pain by draining through the tube. But with this treatment, the obstruction is usually not directly treated. And this could be for a multitude of reasons, but it just may not be possible to resume normal eating and drinking if this is the option that is pursued. Another potential option is bowel resection or internal bypass. So in the case of bowel resection, which is illustrated here, the affected portion of bowel is removed and then the ends are reconnected. For an internal bypass, sometimes it's just not possible to completely remove the affected segment because it's stuck, it's frozen in place, and it's just, we would be risking injury to other structures we don't want to injure if we were to try to dig it out. And so what we can do sometimes is take a loop of bowel upstream and a loop of bowel downstream And these are connected, essentially creating a shortcut to bypass this blockage. So now let's talk about ostomies. And this is what we commonly refer to as a bag because of the pouch worn externally on the skin. An ostomy is made when the two ends cannot be safely reconnected at the time of surgery, or it's made as another means of diverting stool upstream of the obstruction. They're often done when a patient is very sick, and it would be very risky to put the two ends of the bowel back together because whenever we're putting two ends back together, we have to be concerned about potential risk for leak. And if we're concerned about that, an ostomy is a safe option. These are done by selecting a loop of bowel and then bringing it out through the skin to empty into an external pouch. The type of ostomy is named based on the segment of bowel that is used. So a colostomy comes from a section of colon. An ileostomy is an ostomy that's made from a section of ileum, which is the name for the last portion of the small intestine. So while many ostomies can be reversed, there are some that cannot or should not be reversed. Again, we're weighing the risks and the benefits. So the first question, very similar to these considerations of whether or not we should operate in the first place. First question, is it technically feasible to reconnect the two ends? Is there a healthy downstream landing zone, as it were, where the intestine can be connected? Second, is there a risk of significant lifestyle changes such as chronic diarrhea if the ostomy is reversed? I've had my share of patients with ostomies who find it much more comfortable, much more convenient to empty a bag at their own convenience rather than needing to worry about where the toilet is every single place they go or being stuck at home because they're constantly on the toilet. And then there are the risks of surgery and anesthesia itself. Having an ostomy is certainly a change from what most would consider normal. And it's certainly something that so many people live with, and there are so many folks you just would not know they have an ostomy. I know people who regularly swim with ostomies using special appliances and belts. An old mentor of mine, he has a patient who has a permanent ileostomy who regularly runs marathons. And then this is a website that our wonderful former nurse practitioner / ostomy nurse who used to work in our office, she told me about this website a long time ago, but it's called ostomy.org. It's pretty easy to remember, and it goes over so many different things. It goes over life with an ostomy, it goes over conditions that may result in an ostomy. And there's even a page where for every state, it lists basically ostomy support groups. So it's a very good place for some centralized information, excellent education. And for patients who do have ostomies, we always make sure that they go home with home health nursing. And these home health nurses are an excellent kind of first line individual to kind of communicate with the clinicians who are also responsible for continuing to order supplies and everything for the patient. All right. So in our last few minutes, let's just change gears a little and review some symptom management since that was part of tonight's topics. So I'll briefly review management of obstruction symptoms. I know Dr. Pereira already went over this somewhat. And then management of chronic diarrhea / high ileostomy output. There's quite a fair bit of overlap between those two things. So first, how to manage those obstruction symptoms. This is often applicable in places where an obstruction is treated non-operatively. First, the diet. You aim for a low fiber diet, so less than 10 grams of fiber per day. Fiber adds a lot of bulk to the stool, and in cases of obstruction, bulky stool is essentially the opposite of what we want. Some medications that can be used include steroids, the anti-nausea medications, which need to be selected carefully. Octreotide is one of those medications. It's similar to a GI hormone, and it can help reduce GI secretions, but it can be quite expensive. Now, in cases where the obstruction was partial only, and I would say this needs to be done under the supervision of a physician, you could consider addition of an osmotic laxative, such as Miralax, to kind of pull water into the GI tract and soften things up. But again, that should be used in very select cases and under the guidance of a physician. The possibility of further palliative chemotherapy should be discussed with oncology. And then last, there are definitely some resources that we can leverage to help manage obstruction as an outpatient, manage these symptoms so that repeat hospital visits aren't necessarily required. These are folks such as the home health nurses, domestic care, palliative services, just to name a few. So chronic diarrhea is kind of the opposite end of the spectrum, but it can be also problematic. And there are a few reasons it can be seen in patients with ovarian cancer. So when you're speaking with your provider about the issue of diarrhea, you should make sure to clarify exactly what kind of symptoms you mean constitute the diarrhea. So is it the frequency of stool? Is it urgency, meaning a sudden urge to go without any significant warning that may or may not result in accidents? Is it a change in stool consistency so that it's more loose? So generally, when we're referring to chronic diarrhea, it typically means a change in the consistency of the stool. And then it's chronic if it lasts longer than 4 weeks. Causes can include surgery, which is because you have removal of certain segments of the intestine or significant length of bowel. Radiation effects can be seen 1.5 years to even several years later. Or it can even be due to diets that are high in fructose or have these certain sugar-free alternative sweeteners, caffeine, and in some patients who are very sensitive, gluten or fat, these can contribute to diarrhea. Symptoms that are more alarming and warrant further workup include fevers, bleeding, and weight loss, because these can indicate a more serious condition or more acute condition that should prompt further workup. But otherwise, because testing is frequently difficult, expensive, nonspecific, chronic diarrhea can be presumptively treated without a significant amount of further testing, as long as there are no alarm symptoms. So these are medications that are used to treat chronic diarrhea, and there's actually considerable overlap with managing high ileostomy outputs, which is why I've included that in the title of this slide. First, you have your medications that slow down the GI tract, which include loperamide, which is Imodium, diphenoxylate, which is Lomotil, and diphenoxin, which is Modafen. There are opioid derivatives such as codeine, morphine, and tincture of opium that also function to slow down the GI tract. But these tend to be among the last things that we prescribe because of the other side effects of drowsiness, nausea, vomiting, etc. So we tend to leave those as one of the last line of things, but I just put them on this first slide because they function in a similar fashion. In some cases, there's difficulty with fat absorption in the GI tract, which can lead to diarrhea. This is seen in cases where, for instance, the gallbladder has been removed, or where the last part of the small intestine is removed surgically or damaged by radiation. So in these cases, bile acid binders can help with that type of diarrhea. I also mentioned octreotide before for the treatment of obstructive symptoms. Functions in a similar fashion. It can be used to reduce secretions. It can be quite pricey, but for some patients, it is something that we need and it can be very effective. Last, a fiber supplement. So as I mentioned before, with the bowel obstruction symptom management, you want to be on a low fiber diet for that. For chronic diarrhea, a fiber supplement is actually very helpful because the fiber acts as a bulking agent. It kind of acts like a sponge. It sops up some of that extra fluid and can help relieve this watery diarrhea. And frequently, just changing the consistency of the stool can be very helpful to for control. I do tell patients that, I've talked to so many folks who've been on all the different types of fibers, the like powder, the gummies, the fibers, the wafers, and, all these other things. And by and large, my patients say that the powder is the most effective at managing their symptoms, whether it's constipation or diarrhea. Fiber just brings things to a happy medium, and it's pretty magical stuff. So that's the conclusion of my portion of the talk. We reviewed the bowel obstruction management and considerations for surgery, went over some options for surgery when it is an option, went over ostomies and discussed the difference between a colostomy and ileostomy, and went over some management of symptoms. So thank you everyone for listening, and thank you for having me here today.
Dr. Birisan, thank you so very much. That was an excellent presentation, and I cannot thank you enough for that. And I would like to thank both you and Dr. Pereira, both of you, in-depth, insightful, informative, and I think you've really gave people a lot of thought-provoking knowledge to think about. And I want to now go and ask some of the questions that were in the chat. So the first question was, somebody who has gone through surgery and they experience severe constipation after their surgical procedures. What are your suggestions?
So I can take this one since I manage a lot of constipation as part of my practice, but a lot of it comes back to basics. Post-surgery, we're frequently, uncomfortable, not moving around as much, but moving around, walking around is one of those things that's very, very helpful for restoring bowel function. This is in the acute phase after surgery, and this is certainly true even well beyond that. And then, fiber supplement, something like, and then you don't have to pick any one particular brand. As I mentioned before, the powder form tends to work the best, but something like Benefiber, Metamucil, Psyllium, there's Console, Fiber One, so many different options, just whichever one works. A fiber supplement could potentially be helpful, as long as you're not having true obstructive type symptoms. Drinking plenty of water. A lot of patients, a lot of people, myself included, tend to be behind on the amount of water that we should be drinking per day. We should be drinking about 8 glasses of water per day. And these measures alone tend to be extremely helpful in relieving constipation. And then just some stool softeners, stuff like Miralax and Colace. These can be pretty safe to take on a fairly daily basis. I will caution patients to minimize the use of the stimulant laxatives, stuff like Senna and Dulcolax, on an extremely regular basis, because these work by irritating the colon, and the colon can actually become dependent on these medications. And so I would just caution folks to limit the use of those to just something extremely short term.
Thank you so much for answering that. We appreciate it. So the next question is related to bowel obstructions. There is a survivor on the call tonight who has had several bowel obstructions, and 2 of them were not typical. She actually had a good appetite, had normal bowel movements, and she only went to the hospital because her pain wasn't getting any better. And the scan indicated that she had small bowel obstruction. So in that scenario, what should somebody be looking for? What should they be asking their doctor? And also, are there certain foods that somebody that's had bowel obstructions previously that they should be avoiding? Who would like to take that one?
I'll answer part of the question. I'm sure we can both contribute, but
Perfect.
I think that's a difficult question to answer broadly, because it really depends on what was causing those atypical bowel obstructions. Was it an adhesion? Was it, something that was temporary? How were those bowel obstructions managed? Was it surgery? So the question is a little bit difficult to answer. But I mean, I think that everybody's symptoms are different. And so I think one important thing when you're going through this process is listening to your body and understanding it. And I think this patient now will start to recognize maybe her atypical symptoms of bowel obstruction. As far as foods to avoid, I've heard, all over the map of what we should and shouldn't avoid. I have in my own practice seen patients who have these occurring and then resolving and recurring, resolving bowel obstruction. Sometimes a food will trigger it, like eating steak. And so I often sort of recommend eating foods that are easy to digest, which is usually low fiber, but then we talk about keeping fiber in your diet so you stay regular. So it's a little bit of a tricky balance. Dr. Birisan, what do you think?
Yeah, so somebody who has these recurrent bowel obstructions, I would probably advise them to be on a low fiber diet at less than 10 grams a day. And I like to try to keep things simple for my patients. And I frequently put my patients on a low fiber diet immediately after surgery, just because, there may be some swelling to the intestine or something that will kind of inhibit motility. So the short version of that is minimize the fresh fruits and vegetables. Stuff that is cooked tends to be fine. Cooked or canned tends to be okay. Make sure you chew everything extremely, extremely well. And just also observe everyone's a little different. Everybody's bowels behave a little bit differently. Everybody's bowel habits different. And so certain foods may trigger obstructive type symptoms in some individuals that won't in others. And so maybe keeping a food diary to see what exactly could be affecting you.
Thank you. To add to that question, another point is, should they moderate the number of meals that they're eating, the frequency of eating throughout a day? Should it be the 3 main meals, or should they be eating more frequently throughout the day if somebody's had bowel obstructions? Is that a factor?
Yeah, I mean, I think I find that having smaller, more frequent meals can help in that setting. And it's again, it's part of listening to your body. I find that patients who have like a partial bowel obstruction, who have some decreased motility, they're not going to be hungry for a giant meal. They're really only going to be hungry for small meals. And so that's an example of like really listening to your body.
Thank you very much. So one of the survivors on the call tonight shared that her ovarian cancer recurrence led to a colostomy. She was fearful at first, understandably so, but she actually loves hers now and never wants to reverse it. And her quality of life has vastly improved, which is wonderful. So a question that we had before tonight's program began was, if somebody does have a colostomy, and the doctor is recommending that it does get reversed, is there any harm or anything that they need to think about if they would actually prefer to keep the colostomy because they have become very adaptive with that as part of their life? Dr. Birisan?
Yeah, I think that it is perfectly acceptable to keep an ostomy in place long-term or permanently if it is significantly improving the quality of life. I will say that a strong consideration does have to be made for, all right, what does the rest of that downstream bowel look like? And it would be a discussion between the patients and her physicians. Somehow that portion of bowel needs to be, there needs to be some sort of surveillance on it, meaning we're supposed to be, another separate public service announcement, but, age 45 and up should be getting colonoscopies or some sort of colon cancer screening. And even if that particular portion of bowel is out of circulation, it's still there. It could still potentially form something. And so that area may need to have some sort of surveillance. Could potentially, depending on life expectancy and everything, it might be something to discuss. Like, should we just eventually remove it entirely? That's obviously another big operation. So again, weighing risks, weighing benefits, just also need to consider, yeah, that area also needs to undergo some sort of surveillance. That could be a discussion with someone who does a colonoscopy, a surgeon, gastroenterologist, somebody else.
Thank you very much for that answer. Another one of the survivors on the call tonight has had quite a few bowel obstructions that were caused by post-operative adhesions. Is there anything that they could do to minimize this? They have been directed to follow the FODMAP diet, but it has not really helped them. Any recommendations if that was the cause?
So, I mean, the FODMAP diet isn't necessarily a low fiber diet. And so I think in cases of recurrent bowel obstruction, more low fiber. FODMAP is more for patients with like irritable bowel syndromes, more so than for patients with like a structural obstruction. And so I think this is probably a case where a low fiber diet would be appropriate.
Okay, great answer. Thank you very much. So another question that came in, what is your opinion about Ozempic and its effects on chronic diarrhea?
I'm going to pass on this one. I think
Okay.
in many ways, the medical community is also trying to figure out Ozempic and how to work it into our practice. There are issues with delayed gastric emptying, and so we have to account for that pre-surgically. And so maybe Dr. Birisan has more experience with it, but
It's not something I regularly use as part of my own practice. I'm a surgeon, I'm not a gastroenterologist. So that would be something that I would probably direct towards a gastroenterologist. So I'll pass on that question as well.
No, thank you. I appreciate both of you being honest and forthcoming with that. I am going to just ask one other question that was sent to us prior to the program beginning. And it actually, you guys both touched upon nausea. And one of the questions is, with chronic nausea after certain bouts with dealing with the different chemotherapy drugs, one of the questions was, if somebody is taking a lot of anti-nausea medications and that causes an upset stomach for the other situation to arise, they are now having chronic diarrhea. How do you balance the two? What is the best thing to do? And with that said, what should they ask their doctor if they feel like they are just constantly going back and forth between either nausea or diarrhea, and there's no sense of calm in their everyday quality of life? Is there any recommendation?
Yeah, so I think that touches a little bit on one of the slides that I had about nausea and stimulating the bowel. And I think it would be really important for that person to have a conversation with their physician about selecting for anti-nausea medications that don't stimulate the bowel. Medications like Reglan are known to stimulate the bowel and cause diarrhea. Zofran can cause constipation. And so sometimes we select from the menu based on what other symptoms we're trying to either help or avoid. And one of the things that I had actually wanted to mention during my chemotherapy slide was that when you're on chemotherapy, it's really important to keep a daily, almost diary of how you're feeling and what's going on, day 1, day 2, because you're going to most likely be either seeing your doctor or their nurse practitioner before every cycle. These are 3-week cycles. By the time you're seeing this person, you forget what happened 2 weeks ago. And so that you're not in this constant cycle of having symptoms that you don't know how to manage or very distressing, and then you forget what they are, and then it happens again. Keep a diary and bring that diary with you to your visits so that you can really address, on day 5, I was feeling fatigued. On day 7, I had diarrhea. Like, really to that level of detail can be very helpful.
That is a fabulous suggestion because also sometimes you forget all of your symptoms and the questions that you may want to ask. So having that diary could be extremely helpful. One last question that we are going to ask, could you address how common and how to manage post-debulking surgery bowel hernias?
So I saw that question pop up and very quickly looked up some incidence rates, and it looks like it's anywhere between about 10 to 20% for these kind of large debulking operations. That's was a few different papers I really quickly pulled up, not necessarily for ovarian cancer, for colorectal cancer, for appendiceal cancer. So it looks to be about like 10 to 20%. And how to manage it, as long as you're clear, don't have a tremendous amount of ascites, and are okay to have a big have an operation, I would say go to a hernia specialist. There's certain general surgeons who this is what they really love to do, and so that would be that type of person that you would seek out.
And not all hernias need to be repaired. If it's not
Correct.
symptomatic and it's not bothering you, it's not something that necessarily needs to be addressed immediately.
Thank you. Thank you all for your questions. Does anybody have a last minute question that they want to put into the chat for us to ask tonight? Okay, well, the two of you, again, have been very approachable, which we greatly appreciate, talking about a very delicate topic, and have given our audience a lot to think about and a lot of different things that hopefully will help enhance their quality of life. And we thank you so much for your time, and for everybody that participated tonight, thank you so much. And we hope to see you at our next session, which is going to be next Thursday, where Dr. Andrew Medzen from Northwell Health is actually going to discuss my treatment ended, now what happens? Ovarian cancer follow-up and surveillance, another important topic for our teal community. So Dr. Birisan and Dr. Pereira, thank you so much for your time tonight, and we really do appreciate it. And thank you so much for sharing your expertise with us. So thank you so much. And thank you all for joining us. Have a lovely evening.